Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk with Margie Balfour and Jason Winsky about collaborations between cops and clinicians.
We're very lucky to have Margie Balfour and Jason Winsky here to talk about their special article, Cops, Clinicians, or Both, Collaborative Approaches to Responding to Behavioral Health Emergencies. And Margie is the Chief of Quality and Clinical Innovations at Connections Health Solutions, and also an Associate Professor of Psychiatry at the University of Arizona. And Jason is a sergeant at the Tucson Police Department and their mental health support team. Thank you so much for joining us. We're really excited to talk about this article, which is a really crucial topic, and I think a topic across the country right now. People are really starting to focus in more on crisis services. So we're really happy to have you come and talk to us and share your expertise and your experience. So just to start out, I think it'd be interesting to hear a little bit how you both came to this work and maybe what your current roles are. So Margie, why don't we start with you?
Sure. So I'm a psychiatrist, and I have always, since I started my rotation in residency, just loved emergency psychiatry. I started off as a researcher, though. That was, I'm an MD Ph.D. I was going to do a traditional research track. And as I kept moonlighting in psych ERs, during my residency, came to understand that people weren't getting the evidence-based care that they needed. And so really then got interested in emergency psychiatry and community psychiatry. Ended up coming out here to Arizona to help overhaul a struggling crisis center here in Tucson. And then, unfortunately, we had the beginnings of a very sophisticated crisis system out here. And especially with the Tucson Police as our main collaborator, we're really able to do a lot of the work that we talk about in the paper.
Great. And Jason, how did you end up working on this issue
Yeah. So I'm a 17-year veteran of the police department, and almost, 6 years ago, we had quite a bit of incidents and turmoil, actually nationwide and across the country, not just locally here in Tucson, involving police interactions with persons either in crisis or suffering from some kind of mental disability or illness. And so the police department here started what we call the mental health support team. And I was asked to be in charge of it because I was involved with our crisis intervention CIT training program. So it was kind of a natural fit for me to kind of launch this program. And we've just been evolving it ever since.
And how did the two of you start to collaborate?
So with the Crisis Response Center, which is with Connections, and we operate that center, it was built by the county, and it was really meant to be a place for police to be able to bring people instead of taking them to the emergency room or taking them to jail. So just by the very nature of what our center does, police collaboration is an integral part of it. We talk about, if we're trying to reduce the police from bringing people to jail, then we need to treat the police as a preferred customer, similar to how we treat our patients. And so just by virtue of that, we collaborate a whole lot with the police.
Can I just jump in and ask a question? Because why in Arizona, where you guys are, you guys are so ahead of the curve, right? And so where was the vision? Innovation is so important. I'm trying to understand why it happened there.
Why in
Other than
Arizona?
the fact that they had the two of you, which is obviously
So years before Jason and I were doing our thing. I moved to Arizona from Texas, and it's an interesting state because it was the last state to ever have Medicaid. When I moved out here from Texas, I was like, oh, this is great. Look at all this Medicaid. The name of the department is even called Access, which is all about access to care. But it actually stands for Arizona Healthcare Cost Containment System, which, is not what I thought it meant, but it actually explains a lot about why there's been such an investment in crisis services. Because when Arizona created Access, they immediately applied for a statewide managed care waiver, an 1115 waiver, and they were the first state to ever do that. So Arizona has really never had just straight fee-for-service Medicaid. It's always been managed, which means that somebody has to think about it as a system. Also around that time, so this was in the 80s, there was a major lawsuit around mental health called Arnold versus Sarn, which was done on behalf of people with serious mental illness. And the settlement, which took like 30 years to do, ended up guaranteeing people the right to a continuum of mental health care, including crisis services. So you've got those two things happening. And then if you look at the incentives, what I want as a clinician, as a psychiatrist, is I want my patients to not be in jail, not be in the emergency room, and not be in the hospital. If you're paying for stuff, you want that too. So if you're the Arizona Healthcare Cost Containment System, you're going to invest a lot in crisis services. And it wasn't working perfectly in the very beginning. Actually, our two co-founders at Connections, Dr. Chris Carson, Dr. Robert Williamson, they had pioneered the kind of 23-hour observation model in Texas back in the 90s. And Dr. Carson was asked to come and run the mental health system in Phoenix, in Maricopa County, and take over the crisis center there that wasn't serving the police's need. There were long wait times and police weren't accessing it. And he kind of started that, we're going to get the police in and out in 5 minutes or less so that they prefer to come here rather than to jail. That raised the standard for all the various crisis services. And that's been the standard of care in Arizona now for, 15 years or so. So you have that culture, but we also have the framework. And the framework is managed through the Medicaid department. So we have, each region is divided. There's a north, a south, and the central region. And the state puts out for competitive bid to be the behavioral health authority for that region. And they braid together the Medicaid funds, the SAMHSA block grant funds, state general funds for crisis. And so in addition to having the funding for it, we also have a structure where there's accountability, oversight, and governance, because no matter who is in crisis, no matter what their funding source is, on the back end, the funding's all worked out because it's all braided from these different sources. But on the front end, all of us crisis providers are contracted, and we have obligations for the kind of services that we do and how fast we get the police in and out, and what percent we are stabilizing and things like that.
I think what you're doing in Tucson is a good place to start, because the paper really lays out, one aspect of the paper is really laying out kind of like what an ideal crisis system might look like. And you have a lot of those components that you've built out. But what happens? Somebody is in crisis in Tucson. Like walk me through sort of like a typical crisis, what's available to the person, how the police is involved, where they go, and kind of like how they work their way through the crisis system in the system that you all have helped construct.
So the system is set up to be providing care in the least restrictive setting possible, which also is the least costly. So the least restrictive thing is to pick up the phone in your house. So there is a crisis line that is 24/7, staffed by various mental health professionals, and they get about 10,000 calls a month, and they resolve about 80% of those on the phone. They do that via telephonic counseling, or because we have this behavioral health authority structure, the clinics are required to put crisis appointments into their system so they can make people appointments and things like that. If they can't resolve the crisis on the phone, then there are about 16 mobile teams that cover our county. The times that they're working are staggered throughout the day to meet demand. But the crisis line then can dispatch one of these mobile teams to go out and meet the person where they are. If they do a face-to-face encounter, they can resolve about 70% of those in the field. And then for people that need a still higher level of care, we have several crisis facilities. We have two in Tucson. Ours is the largest, that takes the higher acuity involuntary patients. There's another one that focuses more on substance use and detox. And both of those have this model of trying to get the police in and out as quick as possible. So police can drop off there, the mobile teams can drop off there, people can walk in, they can be transferred from ERs. And there is a urgent care walk-in clinic where people can get their needs met quickly if it's just like a med refill or something. And then there's a 23-hour observation unit where people who basically meet the criteria for inpatient, these are the people that would be waiting for a bed, boarding in an emergency room, and danger to self, danger to others, psychotic, intoxicated. And our philosophy is that most of them don't need to be in the hospital if you start treatment early and aggressively. And so about 60 to 70% of folks can be discharged to the community after we've started medications if we need to. We have peers that are doing groups. Our nurses are administering meds, detox protocols. Our social workers are on the phone with their families and their clinics trying to figure out what's going on. And so then after the crisis, there are some post-crisis wraparound services that help follow up with people and keep them stable in the community. And every point along there, there's easy access for law enforcement. So, for example, some of the crisis line staff is co-located with 911 to be able to intercept some of those calls. Some of the mobile teams and Tucson Police collaborate and work together. And then our whole center is set up to service law enforcement, really quickly. So they prefer to use us rather than to jail.
Jason, what's it been like watching this from the law enforcement perspective as it's unfolded?
I think to answer that question, it really goes back to what we were talking about before, and that is what makes Tucson different or what makes Arizona different. I think from the law enforcement perspective, we are just extremely lucky here that we have this whole kind of crisis continuum that Margie just laid out. There's a lot of places around the country that only have one or two of the components you just heard about. And I think there's a lot of places in the country that quite frankly don't have any of the components. I think for us, we do a lot of work on our end, on I guess you might say the front end of this system, in the sense of we have a very robust crisis intervention team training program. We actually just finished a class. We have mental health first aid training, which we do in the academy. We have a drug deflection program. We constantly train our officers to consider jail diversion options, treatment options instead of jail, all of those things. But as much training as we do, and as proud as I am of our police department, a lot of what we do would not work if there wasn't the crisis response center. It's great to believe in diversion and deflection, but if you don't have a place to go, it's kind of all for naught. You end up maybe in an ED somewhere, or you end up somewhere that's not that still perhaps is not the appropriate placement or solution for that person struggling with addiction, or someone who's in crisis, or even experiencing homelessness. I think what you have is a police department and a sheriff's department here in Tucson and Pima County that's kind of primed to use these options, and then there actually is the system, right, that can then accommodate and facilitate those diversions and deflections.
I think the notion of the systems and the structures is the key here, but I'm fixated on something that you said that I need to ask you about, which is these police officers getting all this training. Do they like it? Do they like, for this, I went to the police academy? I mean, how does it go down?
I'll give you the perfect example to describe my answer to your question for that. They love the training here. And, whether it's a culture that we set early on in the academy around training as a positive, whether it's we have a very plugged in, progressive, but also genuinely personally interested chief of police here, Chris Magnus, although unfortunately we might be losing him. He's going all the way up to the federal level here soon to become part of the Biden administration. But we have a chief that also sets that tone of, you need this training. I expect you to make good decisions about diversion and deflection. And, an indicator of that, we just finished a 40-hour crisis intervention team training here. Many people are familiar with that. That's the full 40-hour kind of like immersion training, where we partner with NAMI and all of those things. We're the Memphis model here, right? And that is a voluntary training. We do not make people go to that training. It's multi-agency. We do it in collaboration with the Sheriff's Department and many, many other partners, including Connections and Margie here. We actually run a wait list for that training. We cannot do those trainings fast enough for the people who want to get into that class. And so, we really don't have to force people. People want this training. And again, as I'll just end with, as much as I think we have these great training programs and these great collaborations, the reality is I've been doing this job for 17 years. The people that we're hiring now, the people much younger than me, frankly, they are much more plugged in, tuned in, educated, interested. They don't approach this topic with the stigma that you saw 17 years ago when I started. They don't really say to themselves, why am I taking a class about mental illness or substance use disorder? And this younger generation that we're hiring, I think, is really primed to learn about these subjects, and they're not carrying any kind of judgment or stigma with them. that maybe we did see 20 years ago, especially in law enforcement.
And kind of as a testament to the success of that, when you look at the patients that we get dropped off to us by police, like we do this in Phoenix, we've done this in Texas and other states. And most of the time when the police are dropping people off at a crisis center, they're under whatever your local involuntary hold is. So they're involuntary, 72-hour hold, 24-hour hold, whatever you call it. And the Tucson police is the opposite. 60% of who they drop off to us every month is voluntary. And one of our doctors jokingly calls it the Uber police. But it really is, it really illustrates how they totally buy into it. And they engage with people that maybe in other communities or before they wouldn't have taken anywhere because they didn't meet the criteria to be taken against their will, but they're able to engage with them and say, hey, let me take you somewhere for where you can get some help. And they go with them voluntarily.
One thing that stands out in hearing you talk and reading the paper is that the drop-off centers are places where people who are maybe violent or intoxicated can also go. So I'm wondering how crucial that is, both in terms of like the system and also kind of fostering that buy-in from law enforcement that Jason was talking about.
Yeah, that's crucial. And so I'll talk from my point of view, and then Jason, I'm sure will have things to chime in. But mental health has a reputation for being difficult to access. A lot of places, the joke is it's easier to get into heaven than to get into psychiatric care because there's all this list of reasons why someone can't come to your facility. And there are crisis centers out there that will not take people who are highly agitated, highly violent. And then what happens to them is they end up being taken to the emergency room instead, where they get restrained on a gurney, or they go to jail where they, get restrained and have a really bad experience and are in the justice system. So our philosophy has always been that we want those high acuity, quote, difficult patients that often get refused by many mental health agencies because we think that we have the best setup to be able to meet their needs. We don't use security. We have our trained behavioral health tech staff, peer supports, and the rest of our staff. And we work on training a lot. And we feel that we want those people coming to us so that for two reasons. One is because that's the best thing for the patient. And two, if you were trying to service police and give them a place to go that is a viable alternative to jail, there's a few things that police want. They want to get in and out as quick as possible. They don't want anyone turning them away ever. And they don't want to be hassled about taking their guns off. So that's why we have them a dedicated entrance where they're in and out in less than 10 minutes. And we never, ever, ever turn police away. People always go, well, what if they had a medical issue? Well, one, the police are better than they get credit for identifying who needs to go to an emergency room versus us. But even if they do bring us somebody with a medical issue, our CMO likes to remind us that we did go to medical school, we psychiatrists. We can treat blood pressure, we can treat high blood sugar, but we are connected via a breezeway to an emergency room right next door to us, although our Phoenix facility isn't. But yet we have protocols to stabilize someone and get them transferred. And it's less than 10% of our patients end up needing to go to the emergency room and then come back. So yeah, being able to take everyone, including those who are agitated, intoxicated, is key to making this work.
I really wouldn't want to add too much to that. I think you covered it really well, Margie, but just to deep dive that one of the points she made, and that's the no wrong door policy. It is increasingly difficult for police officers in this country and in Tucson, I mean, all the way around, to navigate and map out these systems. There's new services being offered. There's new clinics. There's the rollout of like MAT services and things like that. There's shelters and there's housing first, and there's all these different systems where police officers are encouraged to take people. But this has become so confusing nationwide that some of the new ideas you see out there, are even, trying to figure out like how to put an app on a police officer's cell phone, and you plug in like what you have, and it kind of like it navigates for you. Oh, take the person here or take the person there. I think we're a long way away from that being, practical, out in the field, out in the street, maybe one day. But in the meantime, it is absolutely crucial for law enforcement to have that no wrong door. There's a lot of things that make the crisis center here work. and that they excel at. But I would really highlight the no wrong door policy, because the officers know this is a realistic, workable, viable diversion option, that in other words, they won't get called back an hour later to pick the person back up, right? That's very key for us.
And we meet monthly. We go over data, we go over the drop-offs, we go over any outliers, any complaints, that our staff was rude or their staff was rude, which rarely happen. But we go over all of that. And so we don't, whenever there is a disagreement or a problem, we both have the mentality of, we're not going to put the patient in the middle of that conflict. We'll just, accept the patient, do what's the right thing, and then work out, was this a system problem? Do we need to change a policy or something after the fact?
Do you have either of you have like a case that comes to mind when you're thinking about how this works well? Somebody who, if they were in another crisis system, would have a bad outcome, but had like a much better outcome because they were funneled through the system that you've set up in Tucson?
Do you want to talk about your lady with the car?
Yeah, I was just thinking about the same one. Yeah, we actually had an example of someone that we were able to take to the CRC that when the police department here put it on the Facebook page, and we actually kind of went viral with it. So yeah, it's a great story. It's a great example. So we had a lady who was in her mid 80s, and she was living in her car in a church parking lot. And the church was actually giving her food and letting her use the restrooms. And I think there was even like, shower facilities. I mean, they were basically her caretaker. This woman was also connected to a provider, a behavioral health provider in town. And, eventually, whatever it was, maybe the conditions that she was living in the car, or she just wasn't complying with her treatment, maybe making appointments, medications, they put in for her to go inpatient. So they put an order in for her to go be evaluated in an inpatient facility. My team and I went out and we were going to go serve this order and pick this lady up. And we realized a couple of things. One is she was living in her car. And the second thing was the car didn't run at all. The car was not drivable. And this car was top to bottom filled with basically all of her life possessions. And while this lady was very nice to us, she was absolutely in crisis, because what's going to happen to her car? What's going to happen to her stuff? She's going to go inpatient, and who knows? I mean, yeah, she could lock her car, but the church couldn't guarantee that they were going to keep her car and her property safe 24 hours a day. So we got kind of really creative here, and we called Margie down at the CRC, and we actually ended up getting a tow truck, and we towed the car with her down to the crisis center. But the CRC actually did us even one better, and they were able to figure out a way that she was able to, for most of the time anyway, visibly see her car from her inpatient stay there at the CRC. And I really love that story for a couple of reasons. I mean, not just because we got creative and we found a solution about what we were going to do with all of this lady's property, but also the quality of her stay at the CRC was probably better. And her evaluation there was probably better because she wasn't distracted the whole time of just being in the crisis of where's my stuff? I'm miles away from my car and miles away from my stuff now. We were able to kind of relieve that tension for her so that she could focus on what was probably even more important, which was getting the evaluation done and, what were her needs moving forward. So it was just a great story that was just a collaboration of a lot of different partners actually in the community, because we were able to get the tow for free, which was pretty critical as well, because obviously she had no way to pay for that. So that's a story I think about a lot.
What stands out to me about that is that can't happen if the barriers to entry haven't already been taken away. So all of that creative thinking can happen once you know that you have like partners on the other end for both parties. Otherwise, there's like, I don't think law enforcement is going to think about calling a tow truck, right? But like once you've taken away some of those barriers and you're not thinking about like, how am I going to get this person into some place that's trying to turn them away? It seems like it opens up people's creativity to solve, because all of these situations call for some creativity, or else people wouldn't be in crisis. There's something that's not going right that you need to kind of think about a different solution for. So it's a great story. I hadn't heard about it before.
And that's what we tell our staff is there can't be a rule for everything in crisis, because I mean, you think you've seen everything and then like tomorrow happens. And so, we have to really be sure what our values are and give the staff and the people on the ground the tools to make decisions in the moment based on their values. And, the CRC, we've done all this, like all organizations, we've listed out our values and guiding principles and all of that. But if you really needed to just distill it down to the simplest, it's safety first, do the right thing for the patient, and follow the golden rule, and figure out how to say yes rather than look for reasons to say no. Because staff know that we'll back them up if they do the right thing. I remember when I was first moved out here, I got called at like 2 a.m. because there was somebody with an order from a criminal court judge on one of the reservations around here, sentencing them to the CRC. And our staff was like, what do we do? Is this legal? And it's like, well, what's the guy look like? Oh, he's pretty psychotic. I'm like, well, bring him in. We'll figure out the paperwork in the morning. I mean, you have to be able to, have the confidence that you are acting in the best interest of the patient, and that the system will back you up if you do that once you hit something where there's not an easy manualized solution.
It doesn't seem like we've been talking about a paper, but I think we have been talking about the paper in a lot of ways, because the system that you're describing in specifics is really the system that you're laying out in the paper more broadly, I think. But I'm wondering if you can talk a little bit, because it's really only one aspect of the paper. And one thing that I really valued about what you wrote is the framing of the paper, particularly the social justice framing that you provide to the issues that you're bringing up. So I'm wondering if you can talk a little bit about that.
Yeah, and the reason that we wrote it, kind of the impetus for doing it, was there's a lot of attention on these issues right now. And it's great. I mean, it's coming from the implementation of 988 and the states and communities realizing it's going to need services to connect to, but also from the social justice side, where there's a lot of attention and agreement on the fact that police need to be out of the business of being the default first responders for lots of things, including mental health. And so what you're seeing is a great opportunity. But then when you look at the news, it's like every day there's a story about some cool program. Like, look here, this community has a co-responder program. This community has a paramedic mental health program. And the reason for writing it was to say, yes, all those things are great, but it needs to fit into a larger system. There's no one single program that is going to solve this. And this is a great opportunity because of the various forces that are creating this momentum, but it's an opportunity to make a system where all the different parts work together. Co-responder programs where you have a mental health person and a police officer responding, those are great for certain situations. Clinician-only teams where it's two clinicians, those are great for other situations. The idea of having it so that the police will never respond to mental health crises, I don't think is realistic, because one, there's situations where it's dangerous, just like the ambulance folks, when it's a heart attack call, they have police clear the scene before EMS goes inside a house. You're going to need that kind of thing for mental health, or there'll be, 1 in 4 people have some kind of mental health issue. So it's not like the police are never going to interact with people with mental health conditions. They need that training. And so it's not a one size fits all. Here's the program, you fixed it. It's all of these different solutions for all these different situations, and a system in which all that is organized.
That's a terrific synthesis. And I really appreciated the comprehensive story that you tell in the paper. And I just wanted to also do a shout out, to the sponsors of the paper, to the National Association of State Mental Health Program Directors and SAMHSA for sponsoring this series that we then kind of shaped for Psych Services. Everybody should read this paper. Everybody in mental health should read this paper, because it's an education, and it's also a synthesis, and it's fantastic.
Well, thank you. And I love the fact that this series of papers came from, spun off from NASHBID's report that is entitled Beyond Beds, because so often when people are lamenting all the problems in the mental health system, we just need more beds. And the solution is so much more robust than that. And so I really appreciate that NASHBID has really, they've got a couple of years now worth of these technical assistance papers that are focusing on what beyond beds do you need to create to have a better system for people.
So what would you add if you could have 3 wishes and enhance your program? What would you do?
Housing.
Yeah.
Oh, yeah. Can we do housing 3 times? Yeah.
I think you've already done it 5.
But seriously, it's a social, we have a pretty good mental health system here. For all the reasons I talked about earlier, of course, there's always room for improvement, but I think a big driver of a lot of crisis and a lot of people's inability to remain stabilized in the community once we've done our part is social determinant type issues. Housing being a huge one, but 20% of our people are homeless, probably more are marginally housed, unstably housed. That's a huge driver. There's data out there showing raising the minimum wage decreases suicide rates. Just people's social determinants issues are what drives a lot of this. And then substance use also. If the world had a really good treatment for meth addiction, that would probably cut out the other half of the crisis demand that we see. So, those are the main issues, I think, that I would love to see solved.
One thing I'm wondering is you all have this collaboration between systems that I think are often at odds with each other. And so you've been able to do this work and really break down some silos. And I'm wondering if that collaboration either gives you some clout or if there's any lessons to be learned about how to break down some of the other silos that get in the way of addressing some of these social determinant questions like housing, poverty, economic issues. Do you know what the special sauce is, and can you kind of apply that across the board?
Yeah, I think so. So I think having the kind of collaboration we do, and kind of like what Margie talked about at the beginning about all of us kind of rowing in the same direction, that does have positive outcomes in the world of advocacy. I think, there's a couple of examples here. One is Pima County here operates a Housing First program, and we're able to go to those monthly meetings and really inform what do we want that to look like. And instead of, the cops being in one corner saying we need this, and treatment being in another corner, and, advocates being in another corner, we're all kind of rowing in the same direction because we know what the barriers are. It's not a coincidence that, just a few minutes ago, you asked the question, what's the area that you really need? And it's almost like Margie and I said the exact same answer. It's because we're that well plugged in together. I think that, expands beyond just housing to the whole crisis system itself. Just next month, starting in January, the Arizona State Legislature is going to be back in session. And Margie and I have been talking with many other stakeholders around Arizona, law enforcement, fire, EMS, communications and dispatch, the treatment community, hospitals and emergency rooms. We have formed a huge stakeholder group statewide to talk about transporting people. That's a great example of your question. We in Arizona, like most places around the country, are kind of stuck with some state laws that require police officers to do the vast majority of mental health transports in the community. Sometimes that's appropriate, sometimes it's not. And so again, instead of individual interest groups or stakeholders approaching our state legislature, trying to just do their thing or get their piece of the pie, we've actually formed this statewide stakeholder group that has many different system partners in it so that we can try and approach our government with like one unified solution. Like, hey, this is it. This is what we need. We need police officers to do some of these transports. We need ambulances to do some. We need the patient themselves to be able to transport themselves, to just voluntarily come in if that's appropriate as well. So I think that's an example of where being unified and on the same page, we can also be advocates.
So we've really just scratched the surface, believe it or not, of what's in the paper. Margie, is there anything else that you think is important to highlight about the paper, and particularly around how you and your co-authors are framing this issue?
We talk about the impact that our inadequate mental health crisis system has on people, in terms of people with mental illness, in terms of ending up in jail or in police encounters. And I think it's important to highlight that all of those outcomes are magnified for people of color because of bias, equity issues. And so we felt it was really important to delve into that. And I can't really take credit for it. One of our co-authors, Aisha Delaney Brumsey with the Council of State Governments, she wrote most of those parts. And if you look in the paper, in the policy section at the end, it has a lot of recommendations for how to make sure that those voices are heard in a way that's not just tokenizing. And the fact that we need to be looking at data. I'm a data nerd, so of course I latch onto that part. But all of the work that we're doing, and there aren't really standardized outcomes for what we should be looking at, but we've started to cut our data in terms of race and ethnicity and compare that with the population and our workforce and things like that. And I think all of that needs to be taken into account. And as these services are expanded and built across the nation, to make sure that those sorts of analyses are part of the planning process. For example, if we're doing all of this awesome diversion where we're diverting people out of the justice system and into the mental health system, the police have a wide latitude in using their judgment for that. Is there bias in that? We need to make sure that we're not disproportionately sending people of color through the justice route versus and others through the treatment route. So I think that's a very important piece of the paper that is sort of needs to be wound through all the other interventions.
And in the paper, it really is woven throughout. It's not just sort of like a footnote at the end. It really does frame a lot of what you talk about when you're talking about the crisis system. Jason, anything else that you wanted to highlight for our listeners?
No, thank you for having us. And I just want to say that I think, to echo what Margie said, these conversations are really important, and talking about these things to kind of start setting that tone for what are best practices and what are the things that we should be doing. And so anytime I think we can have these conversations, it's an improvement for all of us.
So if I could just add one more thing, is that we have a great system here in Tucson, but we're not the only place that is doing great work. There is a program called the Mental Health Law Enforcement Collaborations Learning Sites that we talk about in the paper. And this is a program sponsored by the Department of Justice and the Council of State Governments, where they identify jurisdictions where there are really good mental health law enforcement collaborations. I think there are up to 14 now, including Tucson. And the program allows for or supports technical assistance and site visits. And it's designed to cover a variety of different types of communities in terms of geographical location and population. And so that is a really great resource for people who are looking for examples of what's working.
It really was a wonderful conversation. And like I said, as comprehensive as it was, there's even more in the paper. It's also very well written, easy to read, very digestible. And so, as Lisa said, I think we encourage everyone to read this one, but also hopefully people outside of the behavioral health system will also read it in both law enforcement and public policy. And I think it also has a lot of general interest for how our society can do better in all of these areas. So thank you so much for joining us. It was a fantastic conversation. We really appreciate it.
Great. Thanks for having us.
Wow, that was so important and so timely and so relevant, and we really need to pay attention. And I'm just so glad then that Margie and Jason were willing to spend some time with us. And I'm also glad that you, our listeners, found some time to spend with us. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research and columns. Also, please check out our Editor's Choice topic collections available now. You can sign up for that at appiopi.org/ETOCS, appi.org/etox. And if that's too complicated, you can check on our website. That's where you'll find these Editor's Choice topic collections. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you so much for listening. We'll talk with you next time.
APA Publishing has other podcasts you can listen to. AJP Audio is the podcast for the American Journal of Psychiatry, hosted by Aaron Van Dorn. Psychiatry Unbound is the books podcast from APA Publishing, hosted by Dr. Laura Roberts, editor-in-chief of APA Books. Check out these and others, along with APA's newest podcast, Mentally Healthy Nation, at psychiatryonline.org/podcasts, or you can subscribe via Apple, Google, Spotify, or wherever you find podcasts. The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.